Welcome, my dear friends, colleagues, students, residents, fellows, and of course, all my viewers. I welcome you on MuniMeterHealth, your favorite source of learning about human heart and cardiology. This is Dr. Jaitly from New York, your cardiologist. I welcome all my viewers on MuniMeterHealth. Without any further ado, I'd like to tell you this is purely an educational channel where we offer medical education and patient education, as you see, in order to improve the clinical outcomes, which has clearly been shown now, and primarily by improving the patient health literacy in general people as well as within the doctor community. So once again, welcome on MuniMeterHealth. Without any further ado, as I said, this is not a prescription channel. It's not any medical advice. If somebody's having an emergency, please dial 911 in the United States and get to the nearest hospital, call for an ambulance, or see a doctor right away. But this is purely an educational channel once again. What is PAH? Now, this is pulmonary arterial hypertension. That is the subject, a brief talk in this quick Cardio 360 video that I'm doing here today with you. Well, hemodynamically, by definition, a mean pulmonary arterial pressure more than 25 millimeters of mercury, a pulmonary capillary wedge less than 15, and a peripheral vascular resistance more than 3 Wood units will define a PAH. Now, it may be a little too much for the medical students and maybe the residents, but the fellows should be very, very familiar, obviously, and my colleagues. But the very fact that, we understand this being the right side of the heart, I have a sketch here, RA, and this is LA, left atrium, right ventricle and left ventricle. Now, let's simplify this. Now, as the venous blood is pouring in, obviously it's getting into the right ventricle, which squeezes the blood into the pulmonary artery. Now, this being the pulmonary artery. So we are talking about this pressure. Mean pulmonary arterial pressure through the pulmonary artery should not exceed 25. If it exceeds beyond 25, we are talking about pulmonary hypertension as is. So that is PH. Now, pulmonary arterial hypertension, which is a subsidy of it's like a subdiagnosis of pulmonary hypertension in general. It is primarily because of the arterial narrowing. So primarily the pulmonary arteries are narrower than they normally should be. Now remember, it's like a garden hose, a very simplified thing for the students, I like to say, even for general people. It's like if you like to water your plants and you have a hedge across further up, what do? First thing you do is you press the nozzle so that the stream gets a little further up. And the stream gets a little further up. Why? Because there is a narrowing that you offered by pressing the nozzle. Same principle here. The narrower the orifice, whether it's pulmonary arterial stenosis here or versus pulmonary arterial stenosis elsewhere within the lung, within the chest, those arteries, if they are narrow, the pressure will be high, and that will define pulmonary arterial hypertension. Now, pulmonary capillary wedge is a very distinguishing feature. Now, each time you have a pulmonary hypertension alone, you will have a pulmonary capillary wedge up or down. Doesn't really matter because that will not define exactly what's going on. Now, invariably, most pulmonary hypertensions, if you were to look at all pulmonary hypertensions, they're all secondary to the left ventricular failure or left ventricular disease. So when the left ventricle fails, in other words, it's not contracting too well, so it is not sending blood back into the aorta that forcibly, so the left atrium pressures will start rising. As a result, pulmonary veins pressures will start rising, and then the pulmonary capillary wedge, which is PCW as we call it, that will start rising. So anything related to left-sided will elevate the pulmonary capillary wedge pressure, but that will define pulmonary hypertension. If the pulmonary that's why the distinguishing feature between the two is pulmonary capillary wedge should be less than 15 in order to qualify for PAH. Having understood this pathophysiology, let's move to the central part of my panel here. What is the pathophysiology primarily going on within these patients who have PH? Well, we know the cause is most likely idiopathic. So where the cause cannot be identified, it's called idiopathic. That's a very easy way to know. The second thing is familial. That means there is we have not clearly isolated the gene or the chromosomes, but there has been familial clustering seen, and we don't know whether it's X-linked or Y-linked as yet. And then, of course, there are connective tissue disorders, specifically like example scleroderma. Now that stands out very easily, and polyarteritis nodosa, or we call it PAN, But scleroderma is the prototype amongst the connective tissue disorders, and you can do various testings, but that's beyond the scope of the discussion here right now. So having understood the pathophysiology, the endothelin levels and the thromboxane levels, they both are high. Now remember, these are vasoconstrictors, my friends. Okay, so the vasoconstrictor hormones are high endogenously, endothelins and the thromboxane, that'll result into vasoconstriction. As a result, PAH will occur. On the contrary, the prostacyclins, which are vasodilators, now these are big time vasodilators, nitric oxide and prostacyclins, if they are less, so nitric oxide is also less and prostacyclins are also less, so the whole balance is shifted more towards this side. So less of the prostacyclin and nitric oxide group, higher the endothelin levels and thromboxane levels if you were to do. That'll lead to pulmonary arterial hypertension. But that is the primary problem in all these cases of PAH. Clinical features, how do they manifest? Well, obviously the cardiac output is low, so the patient will complain of weakness and fatigue. Remember, the cardiac output is low in these patients. Dizziness because of the low blood pressures, the blood pressure being low, dizziness, and sometimes even syncope has been reported. Now, dyspnea on exertion, which is very typical because obviously these patients tend to fill up quickly within the lungs and not get enough air. As a result, they are markedly dyspneic as well because of the oxygen deficiency that occurs in these patients. Plus, the tachycardia will lead to, the heart rate will increase, and that can lead to palpitations also as a manifestation. But sometimes an arrhythmia can occur, and most commonly the arrhythmias are multifocal atrial tachycardias or atrial fib, which is very common, and of course SVTs can also occur in these individuals. So that's the clinical manifestation. Ankle edema occurs because it's the backflow problem, so the right heart starts failing. When the right heart starts failing, the right atrial pressures will rise, the IVC pressures will rise, and therefore all the brunt is being felt by the liver here, and therefore it's also felt by the legs here, and you'll have ankle edema. So many of these patients will have unexplained swelling in the legs, they will have unexplained ascites, and then you have to do an echo to ascertain what's going on with them. Now when you do an echo, now this is a very important diagnostic test. When you do an echo, you will see the pulmonary arterial pressure will be high in these patients. They may have a tricuspid regurgitation. I'm writing it as a TR. They may have right ventricular heave, which is clinically present, but right ventricular pressures are also high, and as a result, right ventricle hypertrophy can occur, RVH. Sometimes it's right ventricular failure. We call it right ventricular dilatation will occur. So these are the paramount features in an echo findings here that will be seen. EKG, as I said, may show multifocal atrial tachycardia, heart rate increase or tachycardia per se. Atrial fibrillation and SVTs can also be seen. Sometimes you will see a P pulmonale in these patients because of increased right atrial mass, and that is our right atrial pressures. Pulmonary function tests normally are within range because it's nothing to do really with the lungs unless there's interstitial lung disease where diffusion capacity may be low, but in general this is a good excluding test. Plasma BNP and pro-BNP will rise when the right ventricular failure occurs, but otherwise they are normal because the left ventricle is normal in these individuals. 6-minute walk test is a very prognostic test, not a diagnostic test, but more of a prognosis here, and it defines that these patients can have a very limited 6-minute walking test, and they may turn very, very cyanotic even before achieving a 6-minute walk, or sometimes even may not be able to complete it either and may actually feel markedly dizzy. So it's a symptomatic test, but prognosis-wise, when the patient is being given the treatment, you can reassess these patients on a yearly basis and see if these patients are able to walk beyond 6 minutes, 7 minutes, 8 minutes, 9 minutes, and so on and so forth, and sort of tabulate that and prognosticate. Remember, the clinical course of this illness is unfortunately very, very progressive, and invariably after diagnosis, the PH patients do not survive more than 5 years. So the survival is less than 5 years invariably, despite all the medical therapy, which we will discuss on a different video, not today. Okay, so in a nutshell, you've learned about the pulmonary arterial hypertension, where the mean arterial pressure is more than 25, wedge is less than 15, and the peripheral vascular resistance is high because obviously you'll have pulmonary arterial stenosis, and it's mostly at the arteriolar level. That's where the problems are as a result of this hormonal imbalance, which is more towards vasoconstrictors than towards vasodilators. So vasoconstrictors are more prevalent in these individuals as opposed to vasodilators. So obviously these are your clinical manifestations. Diagnostic tests I've just enumerated here, but predominantly it's the echo. Right heart catheterization is a very, very diagnostic test, but it's an invasive test, and that really defines all these parameters that we just discussed. So you will see a mean arterial pressure once the echo confirms that your RVSP and PAP are high. RVSP is high and PAP is high. One can also see that the pulmonary arterial pressures confirmatorily on an echo, where on a right heart catheterization, where the mean pressures are more than 25. Wedges, of course, is the key, and you have to look at the wedge, and it's less than 15. Invariably, it's about 7, 10, etc. And peripheral vascular resistance is very, very high. It may be 4, 5, 7 units. So depending upon how significant the pulmonary hypertension is, or pulmonary arterial hypertension is. Okay, and most of these patients, they are dyspneic on exertion, but later on may become dyspneic at rest, and that's considered as class 4, just like we define dyspnea. So they are again classified from class 1 to class 4 in that order as they progress higher. Holter is really recommended only in a setting where you have arrhythmias. If you have heart rate arrhythmias, irregularities you come across in the rhythm based on an EKG, or patient is complaining of palpitation or even syncope, I think at that point, or dizziness, I think that you can make a case for doing a Holter or loop recording, prolonged cardiac monitoring as we call it, and those patients can benefit rather remarkably by ascertaining what kind of arrhythmia. We'll be discussing the treatment, guys, in our next video, so stay tuned. This is a very, very short video just on the pathophysiology, clinical features, diagnostic tests, and of course how to define a pulmonary arterial hypertension in this setting where we have the right-sided predominantly getting affected, or it's basically a cor pulmonale as a result that resulting from the primarily lung disease. So thank you again for watching these videos on MuniMeterHealth, your favorite site. Once again, this is Dr. Jaitly. So long, and I'll see you again in my next video. Bye now.